So I'm just going to give you a brief overview of pediatric point-of-care ultrasound, and really most of the time will be spent answering your questions and addressing issues that have come up in your practice. So basically, I'll just have a brief overview of point-of-care ultrasound, and especially in pediatrics, kind of a teaser of some of the applications we use, the future of pediatric ultrasound, and then most of the time will be spent on discussion. So I always like to begin my discussions with a history of ultrasound because everyone is always surprised. They think that we've always had these really small machines. The first ultrasound machine in 1950 was so large that it needed its own room, a large room at that. And the early ultrasound machine in 1954 required that a patient be in a water bath. Not so useful in the emergency department, I would say. And ultrasound became a little bit more relevant in 1965, and Life presented it as to control life, and everyone was really worried that this technology would really take over and do a lot of bad things. And then ultimately in 1975, it started to be a little bit more useful, one of the first quote-unquote portable machines, but still not really portable, not really useful in our emergency departments. Then in the 1980s, it really started being used in our emergency departments. Excuse me. So 1980, early 80s, finally 1999, that was really the small, portable, actual portable ultrasound machines. You can see here, handheld. This really revolutionized our practice in the US. And ultrasound has been so prevalent in emergency medicine that ASAP in 2001 and followed by 2008 had guidelines. So these were really guidelines that not only emergency medicine practitioners, but other practitioners can use as a guide. And ultrasound has been so important in emergency medicine that it is now in the US a requirement for emergency medicine residents to graduate with ultrasound training. Pediatric emergency medicine, unfortunately, is far behind. And I love showing this picture of my mentor, Chris Fox, who's the reason why I did ultrasound. He's really spearheaded an initiative to start ultrasound in medical education. So a lot of you will end up being in practice and having medical students come into your departments and being better at ultrasound than you. So more reason to sometimes be shamed into learning ultrasound. Well, if you're worried about ultrasound technology, it absolutely evolves rapidly to the point where you have small handheld machines. And finally, now in the past few years, we've had pediatric point-of-care ultrasound. We now have a textbook that a lot of my colleagues contributed to, so I refer you to that. And finally, and this is actually very new, in 2015, in May, we published the first policy statement that was jointly endorsed by the American Academy of Pediatrics, ASAP, SAEM, and WinFocus. And really what that shows, I'll give you a little secret because I was on the committee, we kind of stole the guidelines from ASAP and we applied them to pediatrics. But the reason why that was important was that our radiologists were saying, well, yeah, ASAP has these guidelines, but I'm not going to listen to them until they're actually pediatric specific. So that's why we kind of did that. What it really says, in a nutshell, is that everyone really needs foundation. Everyone needs this background of ultrasound, but a 2-day course isn't sufficient. Don't just take a course and go out and think that you're an expert. Each scan needs to have a certain amount of scans and expertise and hands-on experience. Someone needs to review your scans and make sure that there's ongoing quality, and we'll talk about this later. And there are different ways to actually achieve this training. And I'll just breeze through these really quickly, the applications that we use. And there are definitely more applications than what I'm going to discuss today. We start with the basic 6 that ASAP presented initially, and those are the basic life-saving, like trauma, that's a life-saving application, ectopic pregnancy. That's where they all started, but now this is a list that it's growing every day. We're coming up with new applications. And it's really, really changing how we take care of our pediatric patients. So it's a lot, but I like to break down the applications into different categories. So this one is improving procedures. So instead of blind techniques, we now can actually see. We can see in a vessel, we can actually see what we're doing when we're sticking a needle into a patient. This is an example of peripheral IV access in a phantom model. In real life, it doesn't look that good. It's not that easy. Time saving. So a lot of people ask me about the FAST exam, and I've gotten questions from people, well, I've heard it's not useful in pediatric patients, but this is how I use it. It's very time saving. I can see right away in this patient, well, I already know that there's an injury. Someone had mentioned earlier about the lap belt injury. You can see here that there's free fluid in the pelvis. And that's especially important in pediatric patients because that's where fluid is going to be the most dependent portion. Another time saving, does anyone know what this one is? This big target sign, that's an intussusception. So that's a big target sign in the transverse view, and this is the longitudinal view here. My conversations now with my radiologists are, I have a child with intussusception. I saw it on ultrasound. And they don't ask me any questions anymore. They don't ask me if I did a rectal exam and if there's blood in the stool. So it's kind of nice, they actually come in right away. Radiation saving, and there's been a lot of discussion even in this conference on this, and I like to emphasize that one abdominal CAT scan is equivalent to 500 x-rays. So we can use ultrasound, and we can see an appendicitis. So this is the longitudinal view with a fecal lift, and this is the transverse view. It's not all that easy, but we can definitely do it with education and skill. Life-saving, this is my favorite. So even if you were nervous about doing ultrasound or you have limited experience, you can do this pretty easily to see that this heart is not beating. That's an example of asystole, and we can see with our resuscitation efforts, with compressions, with epinephrine, that this patient actually had return of contractions. So this is definitely my favorite. Marianne has seen this at the PEM assembly. This was my ultrasound fellow on Halloween. And he told me that he was on his PICU rotation, and there was a patient that had been admitted for about a week with pneumonia. And because he was my ultrasound fellow, he came to the bedside and did an ultrasound, and this is what he saw. What do you think? That's not normal. So this child actually was in tamponade. This was not respiratory etiology, it was tamponade. He called the cardiologist, and they pulled off 1.5 liters of blood from around the heart. So my fellow saved this kid's life. So that was definitely a shining moment for ultrasound. And then there's the category of just plain sexy. These are sexy applications. Any idea what this one is? This is the heart. This is the peristernal long axis. The heart's going kind of crazy. In case you couldn't figure it out, any idea what this EKG? This is SVT. So when you have a kid with SVT, take them into everybody in the room and show them this. Put the ultrasound on the patient. You will see here the heart's going crazy. You'll see bubbles of adenosine go into the right ventricle, and wait for it. The heart will stop. Wow. I know, right? Everyone always cheers for that. That's so cool. And everyone says that the parents see it. It's very exciting. And then you see return of normal contractions. That's a sexy application. So all of these applications, and there are so many more, that we have challenges. So luckily our adult colleagues of ASEP, they've actually paved the way, but we still face challenges, and we'll talk about this. You really need buy-in from your department, from your hospital, and you need to tailor your education for your experience and for your situation. So this definitely goes for our colleagues in the developing world. Collaboration between different departments. Sometimes it's a good collaboration, sometimes not so good, but try and work with what you have. And the most important thing that we can't emphasize enough is that documentation and quality assurance is really important. We don't want people just going and doing ultrasound unregulated. So the future of ultrasound, having dedicated pediatric courses on many levels, continuing education, research, and even fields within pediatric ultrasound. So this is just an idea. When I started, there were 3 of us that did pediatric ultrasound, and this was a year and a half ago, the pediatric P2 group that Tanya and I were both a member of. There are a ton of people that are a member of this, and it's really exploding, so it's really exciting. If you're wondering where you can get training, I mentioned yesterday WinFocus. I know it's coming up soon. At the World Congress, we do have a 2-day pediatric course. And my favorite, and Marianne's project, that's one of my other favorite conferences, is the Advanced Pediatric Emergency Medicine Assembly. This was the first year that we did an ultrasound workshop, and we're coming up on the 3rd year. So mark your calendars, it's March 7th to 10th in Orlando. And then now is the best part. So we'll get your questions and we'll discuss, and I'm sure there are a lot of issues that we can go over. I didn't even tell her to do that.